sources were simply that, natural occurring radiation sources like cobalt-60 that were or created radioactive elements that emitted energy. And the difference between brachytherapy, where the source is implanted in the body, it basically means therapy at a short distance. That's where brachy comes from. And teletherapy, which is where you lie on the table and the big machine spins around you to deliver the radiation, that's teletherapy, so therapy at a distance. So most modern radiation therapy, 99.9% of it is teletherapy, and a small portion of it is brachytherapy. Brachytherapy is used most commonly, for example, in the prostate, where it's probably most frequently practiced. There are other applications for it in recurrent gynecological tumors or breast tumors, not really for liver or soft tissue sarcomas, and then brain. So I started working with brachytherapy for brain tumors back in the 80s when I was a fellow at UCSF, 1988. And the program there was started actually in 1984 by Philip Gutin, who was a neurosurgeon at UCSF. So I did my second year fellowship with Phil and learned how to do a type of brachytherapy for malignant gliomas with an isotope called I-131 and a stereotactic procedure that involved applying a stereotactic frame, drilling small holes, passing catheters with dummy seeds, taking x-rays after the dummy seeds were placed, digitizing the potential dose distribution, and then figuring out how many sources, what spacing you needed to get a good conformal dose distribution. The use of brachytherapy for malignant, recurrent, newly diagnosed gliomas and recurrent malignant gliomas was proven not to be more effective than some of the newer chemotherapy agents. We essentially abandoned the use of brachytherapy for recurrent malignant gliomas and newly diagnosed malignant gliomas back in the early 2000s. Okay. There was a prospective randomized trial that was done by the Brain Tumor Study Group for newly diagnosed glioblastoma, where the patients were operated, then implanted, then radiated. And there was no difference between that group and the group that had surgery and then just standard radiation therapy. So that put the nail in the coffin for upfront brachytherapy for newly diagnosed malignant glioma. The real, I think, opportunity or application for the brachytherapy is for brain metastases, which are when the tumors are very large, too large for radiosurgical treatment, and the patient's in trouble, then you can, even with a newly diagnosed brain metastasis, you can remove the large one and do the implant at the same time as the operation, so the patient doesn't need any follow-up treatment after that.
And I'm sorry, that's what I know Dr. Kotecha mentioned, that there has to be basically surgery, or a cavity, if you will, and then determine whether do a pathology report even during the surgery to determine if there's still malignancy.
Right. So that's very true for recurrent tumors, which is the most common application, but same for a newly diagnosed tumor. It's not as difficult with a newly diagnosed tumor. It's obviously it wasn't there before you send pathology. It's a tumor. You can do the implant.
Right.
Where the patients had prior treatment, whether that be surgery, radiation therapy, radiosurgery, and you think the imaging features are consistent with recurrence, then for sure you have to send a intraoperative biopsy specimen to confirm the presence of recurrent tumor, because you wouldn't want to implant radiation necrosis with more radiation energy, because you just make the problem worse.
Okay. And I know I was reading about, and I know GammaTile will probably stay away from mentioning it specifically, but it is a very specific delivery method, if you will, a device, which was approved for, I believe, certain brain tumors in just this past January.
So I have tell you that
Or am I,
there's nothing novel about the GammaTile except
Okay.
for the carrier. That's it.
except for what, I'm sorry?
Except for the carrier that it's
Okay,
in.
right,
It's that
okay.
collagen sponge carrier.
Right,
We frequently used iodine 125 sources for brachytherapy, either as single seeds or in vicryl suture strands to do the implants in the past. When I left UCSF in February 2020, that was one of the last operations I did in that month was for recurrent brain metastasis. And we switched from iodine 125 to cesium 131 on the basis of theoretical modeling of resection cavity constriction and the dose to the surrounding brain.
okay,
The motivation to do that study was a publication by the Cornell group where they were using cesium 131. We were still using iodine 125, and they claimed they had no necrosis, but they had no data to back up that, not that I saw, that was that would back up the concept where the dose to surrounding brain was less with the cesium. So we did the theoretical modeling. In fact, it was true.
Mhm.
As soon as we did the analysis, we immediately stopped using iodine and switched to cesium.
okay.
Now, cesium it's a different isotope, same energy of photon that's emitted compared to I-125. It's just that it has a much shorter half-life. So it's 6 days as opposed to 60 days.
Okay.
So that means that the activity and dose rate declined by 50% in 6 days as opposed to waiting for 60 days. So there are advantages to the cesium. The cesium delivers a dose over a much shorter period of time, so there could be a higher biologic effect on tumor tissue with the cesium. And I don't know of any results that prove that there's a significant difference between the two isotopes in terms of clinical outcome. There is a theoretical basis why the toxicity should be less with cesium as compared to iodine, and that was on the basis of the paper that we published.
Okay, let's go to the patient, the brain tumor case where Dr. Kotecha talked a little bit about it, and I mean how you got involved in that surgery. And I know it involved GammaTiles, and he actually showed me one up close, and it was like little tiny capsules, if you will, encased in this wafer, if you will, tile.
Yeah.
Which has its benefits, I guess, to some extent with this case. Can you talk a little bit about this case? The first, I believe, in Florida, if I'm not mistaken.
Yeah, it was a patient, was a woman that had a recurrent brain metastasis from lung cancer and had prior treatment with surgery and radiosurgery, and then there was evidence of recurrence in a short period of time. So that would be the situation where you would use it. I think I sent Katie 18 publications on brachytherapy earlier today.
Mm-hmm.
That I've written over the years. The reason I got involved with it is because I'm the old dog, and so I have the experience, and Dr. Seelman's never done a case, so in order to be able to do it independently, I have to watch him or participate, do 5 cases. There's nothing dramatic about doing the implant. It's really pretty straightforward. So the one thing I don't honestly want to do is make it out that GammaTile is some new novel form of therapy, because it isn't. It's a new company.
Right.
They're touting it as like the greatest thing since sliced bread, which I have a problem with.
Right.
So we have to be really careful about how we,
How do we characterize then this case as? I mean, we're saying first in Florida. Is that because of GammaTile, or is it because it was a unique delivery method, if you will, of brachytherapy for brain tumor?
Here's what it is. It's you're in marketing.
Yes.
Right?
You sure are.
That's what it was all about.
Yeah.
It was GammaTile marketing. It had
Really?
nothing to do with anything else, really.
Right. Right.
And the GammaTiles are 10 times as expensive as a suture, as the sources in Strand.
Right.
And, that's the only time I've done over 200 cases in the past 20 years, 30 years. And I found it in some ways more cumbersome to use the GammaTile because the carrier swells up, and I didn't find it as user friendly.
Really? Okay.
And there are advantages to a well organized, a company that sets it up properly, trains individuals around the country, sets up a registry, et cetera, et cetera. So, and, I'm a fan of brachytherapy, so I think the fact that it's being used more is good for the patients. It's not me. I mean, it's not that, just because I had an interest in brachytherapy in the past, I think everybody should be using it. But I do think that it does have definite advantages, and there's a really long tail survival for about the third quartile of patients. And if you use the brachytherapy in a recurrent setting, not only killing tumor, but you're probably killing some normal tissue around the edge, radiation necrosis, and that probably sets up an inflammatory response that, as a secondary bystander effect, there's an immunological effect, and that may have something to do with the long-term tumor control.
If we don't mention GammaTile at all, if we take it out of the picture, was this still a? I mean, we say first in Florida, but that was referring to the GammaTile, correct?
Correct. I doubt it's the first brachytherapy case in Florida, but I don't know.
But regarding
can we confirm? Is it the first brachytherapy at Baptist Health?
Yes.
Yeah.
Yeah.
Yeah, that we I think.
John, that's definitely a check mark there. But I still want to see how we can weave in something else. Although I know that it is marketing for GammaTile, I do see value in it. Just the fact that we're using. I mean, is the technology in any way, shape, or form top of the line at all, or do we think it is, like you were saying before, it's actually not even that great? I mean, are you?
No, it's just a different carrier. It's more convenient in terms of the implant. That's all.
It's evolving technology, and this is one.
Yeah, evolving technology in terms of the carrier, not the anti-tumor effect.
Right. Because he mentioned, Dr. Kotecha, over the years using seeds or ribbons, if you will, or
same thing.
Right.
But I mean, by the way, Dr. Kotecha said the patient was willing to speak about this. If you want to go as a patient testimonial, but that's up to you guys. I don't know.
Yeah.
He said
so up to 80. It's fine with me.
Yeah.
So, I think what we have to be. I like to be. My wife complains about this. I'm very data driven, which means I'm black and white. I'm flat. I don't get, emotional about stuff. I just deal with the facts. I'm really good when there's a crisis, but I'm not so good when something great happens because I'm still the same. So she can't tell whether I'm happy or who she says. But I like to deal with the facts, and if there's published data, and there are other people that have published on their experience after me, and I think largely because of the work that we did at UCSF over 25 years, people finally realized, hey, maybe we should try this because the other stuff is, not working. And there's certain cases that are appropriate for brachytherapy that are not appropriate for radiosurgery, for example. So those are the cases where the tumor is too big in dimension to be safely treated with a single session or 5-session radiosurgery. Whereas if you're operating to remove the mass and then do the implant, it might be safer or more effective. However, the brachytherapy is an invasive procedure, right? You got to have an open operation. You have to have anesthesia. You got to stay in the hospital. Radiosurgery, you come in as an outpatient procedure. Come in, go home, same day. A couple hours later, you're done. So, big difference.
But we can say that in terms of brain and neck cancers or brain tumors in this case, it's more evolving. It's the very latest frontier of brachytherapy, if you will. Since over the years, prostate and GYN cancers and such, it's been.
What I would say is that it provides for a more organized network and method of delivering brachytherapy across multiple institutions.
All right. Anything else we want to say about the brachytherapy?
Oh, here, let me see. Hang on one second. Let me see if I
John, I do think for this particular story, we should focus on the technology and not the patient.
Yeah. Okay.
And we'll talk about the first in Florida and that claim.
Yeah, because I think the brain, being a brain tumor, and obviously my MNI involved, and Dr. McDermott. Yeah, no, absolutely. I mean,
And Dr. McDermott will obviously, send it over for your review and approval too, so you can give it your blessing.
Yeah. Okay. What the hell?
I think for the health consumer out there, they understand basic radiation therapy,
Yeah.
and then that this is internal radiation, which they may not realize has been around a long time.
Yeah.
But this is the latest, most evolving area, and we're on top of it. And, with Dr. McDermott here, even more so. So.
Do you guys think we should tweak the social questions to be more what is the difference between brachytherapy and teletherapy instead, and maybe do like the pros and cons or differences? Or what do you?
Those are two terms that are not well known in for health
I
consumers.
would just, maybe go to basics, like what is brachytherapy?
What is this versus what is?
Versus traditional internal radiation, external radiation, if you will. I know it's those are rudimentary terms, but most people don't understand brachytherapy versus teletherapy. Teletherapy sounds even like something else, like telemedicine.
Right.
So we got to be, from the editor-writer here,
Right.
and former journalist, we have to speak to the health consumer out there.
So do we want to move, John, did you get sufficient information for your blog?
Oh, I'm
story?
fine. I'm fine. I mean, if you all want to do something, for video, that's fine. I'm fine with for my
With
blog,
what you have?
for my purposes. Yeah, I'm fine. If I have any questions, I'll email Dr. McDermott. But
Great.
I think I'm good.
Okay. And then we can go on to the social video. Dr. McDermott, for this, we're